Aló, aló. ¿Está bien? No, no hay volumen. Ahora sí, sí. Buenos días a todos. Vamos a dar por iniciada la sesión del día de hoy de este simposio. Lamentablemente, Tamara está con problemas para llegar porque hubo un accidente, así que viene en camino, pero en honor al tiempo vamos a iniciar la sesión. Entonces invito a la doctora Sandy Davic, que va a dictar su conferencia Rol de receptor de LL oxidado similar a la lectina en la disfunción vascular materna en la preeclampsia. Sandy.
Thank you. Oh, it's a different one. Yeah. And point is this one? Yeah, perfect. Good morning, everyone. Glad to see everyone. It's good to see everyone back. Looking forward to the posters this afternoon. So thank you for being here so early in the morning. So yesterday I talked more about the fetal and development and impact on later cardiovascular health of the offspring. Today I'm going to talk on preeclampsia, more on the maternal side. So preeclampsia, many in this room know, because it was introduced a bit yesterday, is a de novo onset of hypertension and proteinuria that occurs after the 20th week of gestation or end organ dysfunction. So it's a syndrome, and it's still not even clearly defined. It used to be you had to have proteinuria, now it's end organ dysfunction. So keep in mind it is a syndrome because there's a lot of different features of preeclampsia that can result in the same symptoms later in pregnancy. It's actually very common, 5 to 7% of all pregnancies. That's a very high statistics. And its leading cause of maternal neonatal morbidity and mortality. Morbidity, it's about the cardiovascular health of the offspring and the mom, but also preterm birth because the delivery of the baby. And it also is dire in that it results in actually the highest cause of deaths worldwide. And if you're going to be a maternal death in a developed country, it's usually because it's preeclampsia. And the only definitive treatment is delivery still. So there are ways to reduce the symptoms, but not enough to actually carry out the pregnancy. And so it's thought that there's circulating factors released by the placenta that is causing some of the vascular demise. So what makes preeclampsia very interesting, first of all, you're always dealing with two patients, so we're not thinking of treatments. There's Tammy. Hey, welcome. Always thinking about two patients and treatments, and we'll talk about that later. But what you have is you start with an abnormal placentation, results in hypoperfusion, release of circulating factors, endothelial dysfunction, oxidative stress thought to be our primary player, increased contractility, increased vascular resistance, which is actually going to reduce blood flow to the placenta. So you can see it's just a feed-forward progression. And once the signs and symptoms of preeclampsia come on, it just continues until delivery of the fetus, and more specifically, delivery of the placenta. So it's that feed-forward progression that you see in this syndrome. So what you have is hyperperfusion of the placenta, and a release of a variety of factors. These are just a few, and there are a few that have been identified quite clearly and are used now as biomarkers. You heard about the extracellular vesicles yesterday. I will talk a little bit about those today. And then reduction of protective factors, resulting in endothelial dysfunction, circulating factors, endothelial cells are the first line of defense, and you have reduced vasodilation and constriction. So we've been asking whether there's a conversion point, and this is the lectin-like oxidized LDL receptor. So could this receptor be a conversion point of why the syndrome, which is a lot of different mechanisms and causes for it, ultimately results in similar symptoms, and whether or not there could be a common mediating pathway? And why we are hypothesizing this is that all these factors, and you can see TNF-alpha is there, angiotensin 2, endothelin, oxidized LDL, can increase the expression of LOX1. All of the receptors are increased in preeclampsia, have been identified to be increased in preeclampsia. LOX1 is very much a receptor that's been identified in hypertension, diabetes, hyperlipidemia, and atherosclerosis. It's a very high level of intense research in this area, clinical trials on LOX1. And preeclampsia has only just been identified, well, not just, it's been there for a long time. We identified LOX1 expression increase since 2009, but we need more and more people working on LOX1. And I know Rob and Tammy, I'll be showing some of Tammy's data when she was in my lab later on. So we think LOX1 is critically important. So what is LOX1? It's common in vascular inflammation, atherosclerosis, obesity, and endothelial cell dysfunction. It activates NADPH oxidase, so it generates that oxidative stress I referred to earlier as a common mediating pathway. And it's initially discovered as the receptor that binds oxidized LDL. It is the primary receptor for oxidized LDL, hence its role in atherosclerosis. But interestingly, it's also a scavenger receptor, and it's known to be a scavenger receptor for platelets, inflammatory cells, bacteria, and it's definitely a scavenging receptor. So when you think about that in pregnancy, we wanted to ask whether it could be a scavenging receptor for the placental syncytial trophoblasts, the extracellular vesicles. And if you look here, this is a great, Chris Redman had done this work back in 2011, where he showed the syncytium. And look at this chaos of these preeclamptic placentas. They basically have debris being released under controlled conditions, extracellular vesicles. They're unique to pregnancy, and they're increased in preeclampsia. So we wanted to ask the question if they could actually activate this LOX1 receptor as a mechanism for how the placenta can have direct effect on vascular function. So here's a schematic. I think this came actually from Tammy's work, where we had extracellular vesicles binding to the LOX1, and oxidized LDL is a known receptor for it. It gets internalized, activates NADPH oxidase. You can see now how that can scavenge nitric oxide, resulting in vascular dysfunction. So to test this work, we first did extracellular vesicle collection by doing a perfusion of human placenta. So it was a human placenta perfused collection of the extracellular vesicles, which was well described yesterday of how that's done. And then we took those extracellular vesicles and put them on pregnant uterine arteries from Sprague-Dawley rats with and without LOX1 antibody. Actually, this is work from Rob, who was here yesterday. He's not here today. But what we saw was in the presence of these STBEVs, you have reduced endothelial-dependent relaxation. So this is methacholine, endothelial-dependent relaxation. If we did this in the presence of the LOX1 antibody, you see that it actually brought that impaired response to fully relax the blood vessels. So these STVs was working through the LOX1 receptor as shown with this LOX1 antibody blocking peptide. And if you looked at nitric oxide contributions, so if you add L-name to the bath to block nitric oxide, it actually, these blood vessels actually rely very heavily on nitric oxide, and you can see that the differential of this is that you have reduction in nitric oxide relaxation, but if you have the LOX1 antibody, that allows for the nitric oxide dependent relaxation in these blood vessels. So we feel that LOX1 is maybe a point of convergence for impaired vascular function and could be how EVs can have direct role acting through a receptor, not just being a cargo for releasing factors as we heard about yesterday. And that EVs can impair this endothelial-dependent relaxation by reducing nitric oxide contribution. So going back to the schematic, a lot of factors, because it's a syndrome, it's not, preeclampsia is not one condition, one system, so you can have different initiating factors for preeclampsia could play a role in increasing LOX1, and they have different ligands, whether it be the STBEVs or the oxidized LDL, which is very well characterized. So we wanted to ask if there was a role for LOX1 for at-risk women. And what do I mean by that is this excessive hypercholesteremia in pregnancy is a risk factor for preeclampsia. And what this meta-analysis showed is that maternal hyperlipidemia results in increased risk of this hyperlipidemia, and particularly cholesterol, where preeclamptic women experience the largest changes in lipids during pregnancy. So in normal pregnancy, cholesterol levels have to go up in order to support the fetus and the developing conceptus. But about 25% of women have this excessive hypercholesteremia that occurs during pregnancy that results in this increased risk for preeclampsia. So what are we thinking in this world about hyperlipidemia and LOX1? Well, hypercholesterol levels, hypercholesteremia is known to increase oxidized LDL, and we see that in our model systems. And we wanted to ask whether excessive pregnancy-specific hypercholesteremia can activate LOX1, leading to endothelial cell dysfunction. So now we're into an animal model where we are only feeding the high cholesterol diet during pregnancy from days 6 to 20. And it starts here in order to allow for implantation. And this is critically important because when you look at high-fat diet or other Western diets to create a phenotype, it takes weeks. It takes like 12 weeks. We're only doing it through a pregnancy of like 14 days. And so keep that in mind. And we're starting the uterine artery because we are interested in the pregnancy component of this. And we looked at endothelial-dependent relaxation through a variety of inhibitors. And just to keep it simple, what we have is the nitric oxide pathway, prostaglandin pathway, and then the inhibitors to those. So this is an inhibitor to LOX1, L name we've heard about today, and then this is prostaglandin H synthase. You have the constitutive form, inducible form that can create the prostaglandin pathway. So first of all, the model system, now this is in rats, had the fact that in normal pregnant rats, you'll see a reduction in blood pressure over time. So even though blood volume goes up, your blood vessels relax and blood pressure can go down if it's a normal pregnancy. This did not occur in the hypercholesteremic animals, excessive hypercholesteremic animals, in either systolic or diastolic function. And we did see that these high cholesterol diet-fed dams do have proteinuria, which was absent in the control diet. So this is a phenotype that has been a very consistent phenotype. It's actually, it can be done over and over again. Sometimes you lose phenotypes in your model systems, but this one has a very strong phenotype where in the controlled pregnancy, uterine arteries relax. If you have been fed a high cholesterol diet for only 2 weeks, you get this rebound. First you relax, but then you get this major vasoconstriction at the very end. If we use a LOX1 antibody, well, a LOX1 inhibitor, sorry, BI-0115 is the LOX1 inhibitor, this didn't bring it back to full relaxation, but it prevented that constrictive rebound. And when you look at nitric oxide, again, these blood vessels of uterine arteries rely very heavily on nitric oxide. You can see that it does not relax in the presence of a nitric oxide synthase inhibitor. So you can see that the nitric oxide contribution is much greater in the control animals than in the HCD, high cholesterol diet animals. But then we were asking, because of this rebound effect, was this really reduced nitric oxide, or was there an actual active vasoconstriction that resulted in this rebound that you saw in these uterine arteries? So we looked at the prostaglandin pathway, which can produce both vasodilation and vasoconstriction. And what we found was that in the presence of meclofenamate, which blocks prostaglandin H synthase inhibitor, it also prevented that rebound constriction. So we feel that there was a greater constriction that was occurring, not just a reduction in a relaxation aspect. And when we looked at the inducible form of the PGHS2, which comes up with inflammation, we didn't see any effect of that inhibitor to reverse this vasoconstriction. So in high cholesterol diet and pregnancy, it did induce a preeclamptic-like phenotype, which included high blood pressure and proteinuria. It impaired uterine artery endothelial function. And really very interesting that inhibition of the LOX1 PGHS1 axis, which has been shown in literature to be an axis, but this axis was really quite important in the uterine artery endothelial cell function. So we feel that this excessive hypercholesteremia in pregnancy can actually result in the complication of pregnancy through the LOX1 PGHS activation. And having said that, is there a potential for therapeutic targets? So we keep on looking at LOX1, thinking one day we'll be able to use a LOX1 inhibitor in pregnancy. But there has not been a new medication for a pregnancy condition in decades because of the potential impact it could have on the fetus. Hence, yesterday, my lab's been looking towards a placental targeted treatment. Any treatment you have to a mother may affect the fetus, and therefore, and even vitamin E and C trials were stopped because even as simple as vitamin E and C actually had negative effects on growth for the fetus. So what can we do that can actually help women today, because we still have 5 to 7% of pregnancies having preeclampsia? So we've gone back to low-dose aspirin. So low-dose aspirin is given to women at risk for preeclampsia. It's given around 16 weeks of gestation and then stopped towards the very end of pregnancy. At risk, though, that means that they've had a previous preeclamptic pregnancy, or there's a history of preeclampsia in their family, or they have high BMI. One thing it's not on the list is excessive hypercholesteremia. It is not a criteria for low-dose aspirin. So we know that low-dose aspirin, in part, even though it's a very simple, it's not simple. Aspirin is not simple, but it's thought to primarily inhibit PGHS1, but it's actually known to inhibit LOX1 activation as well. So whether or not aspirin can work on a hypercholesteremic pregnancy was not known. So we want to see if there's yet an unidentified subpopulation of women, remember 25% of pregnancies, who can maybe benefit from low-dose aspirin. So again, back to our model system where we have a high cholesterol diet starting at day 6. Then we have one group started on low-dose aspirin at GD10, which is equivalent to the beginning of the second trimester, which you would see in how humans' pregnancies are prescribed aspirin. And we looked again at endothelial-dependent relaxation and uterine artery blood flow. So look at what the aspirin did, which was, we were just shocked. It completely prevented that rebound that you see here. We couldn't even test really any inhibitors there because they're completely fully relaxed, which was great. So it looks like aspirin really has a control. Now, some of you might say, wow, this is a very high level of methacholine that's being used to cause this end effect. So we did look in vivo. So we do an ultrasound of blood flow velocity, and you can see that in the high cholesterol diet, you actually have an increase of velocity, which is not good. It can create a turbulent flow in the placenta, impairing the oxygen exchange. So it's not good to have this increased turbulent flow. In the presence of aspirin, you can see here it reduced it back to normalizing of the control diet. I'd also like to point out that aspirin in a control animal actually created that increased turbulent flow. So we don't want to start putting aspirin to all pregnant women. And I think that's a really important case because some people had actually advocated for that. If aspirin can, and aspirin does not prevent preeclampsia. It can reduce the risk and incidence. So people do, it's very highly prescribed. But I would argue that we'd want to be very careful and only give aspirin to those at high risk. So low-dose aspirin can improve uteroplacental function. I think it's something we've really started to champion, and we'd like to see this tested. It can improve uterine artery function, and we think it's likely through the PGHS LOX1 pathway. But at least in North America, and I don't know in Chile, hypercholesteremia is not one of the criteria used for initiation of low-dose aspirin in any of the guidelines, and we don't actually measure lipid levels during pregnancy. So we don't know who's at risk. And I think, and that's such an easy thing to do, but we actually don't do that. So we're trying to champion changing guidelines as well on that. So we think low-dose aspirin may offer a therapeutic mitigation to the hypercholesteremic in pregnancy. And I'd just like to finish with the impact of pregnancy complications on later life. I'll do this very quickly. I just added this last night because I think it's important that we think about this, that pregnancy is not just about the 9 months, whether it's impacting offspring later in life or impacting the mother's health later in life as well. So when you look at this stats, 2 out of 3 women who have had preeclampsia will die from cardiovascular disease. They are at high risk. And they're at high risk where their heart disease is 4 times the risk of someone who has had no pregnancy or uncomplicated pregnancy, with stroke being 2 times the risk. And we know that women who have experienced preeclampsia may have impaired vascular function, which is actually very much a hallmark of cardiovascular disease. So our question was, is hypocholesterolemia pregnancy a significant risk factor of cardiovascular disease? What about that short time during pregnancy, which is happening, that can contribute to preeclampsia? Does this impair cardiovascular disease later in life? And this is where Tammy comes in. So Tammy did this in the lab with mice. I don't ever want to go back to mice, but I really like the rats work. But Tammy did it. Tammy actually set up this model based on a model out of Vermont. Really spent a long time getting the mouse work going. And I should just have Tammy present, but I'll do it very quickly. That she studied postpartum. So the animals, just like the rat studies, they were actually put on a bit later because she was finding a lot of pups were not surviving. So in this, you even shorter duration, 6 days in the mouse, high cholesterol diet. So remember that. That's the only insult. The only insult was high cholesterol diet for these 6 days. Studied them 3 months later, which is about 10 years equivalent in humans, which is where you see the cardiovascular and endothelial dysfunction occurring in women who've had preeclampsia. And then used the aortas, because again, we don't care about uterine arteries later in life. We care about the other, and this one's a large artery relative to any risk for vascular disease later in life. And what she found was exactly that just by that short amount of time on a high cholesterol diet, if you had been exposed to it during pregnancy, here it is postpartum or relaxation, those who had been on that 6-day diet only during pregnancy had impaired relaxation. And this did not occur if you were never pregnant. So what she also had, which was on that chart, if I could show you, 6 days of diet in dams that were, well, they weren't dams, and mice that were not made pregnant. So if you were never pregnant and were exposed to that same diet, you didn't see this. So there was something about that diet that caused that preeclamptic phenotype that actually damaged blood vessel function. So really exciting. So HCD diet did not impair vascular function if never pregnant. It only does in pregnancy because it creates that preeclamptic phenotype. So then we looked at nitric oxide, the L name. Again, the aorta also relies very heavily on nitric oxide, and you can see that the differential is there. And seeing the data yesterday where you showed an increase of eNOS, I forget which one showed that, we saw that also in this model. But what happened is actually less activity through the serine activation and an increase of iNOS. And I remember you asked that question, if there was a change in iNOS in that presentation. And then she looked at oxidative stress and found increase of superoxide, more peroxynitrite in the presence of that nitric oxide and oxidative stress, and a reduction of superoxide dismutase, which is a scavenger for superoxide. So what we have here is the fact that we had this reduced relaxation. So now we wanted to know, could it be through LOX1? We haven't actually shown that. So we added oxidized LDL on a normal vessel. Nothing really happened. But look at what happens when you add exogenous oxidative LDL on that postpartum blood vessel. It actually further impaired relaxation, suggesting that the oxidized LDL that we put in the bath bound to a receptor, likely LOX1, that created that impaired relaxation. So have we proven that it's LOX1? Not really. So what Tammy did was have our knockout mice, and again, due to time, I'm just going to show this one bit of data where there was absolutely no effect of the diet, of the exogenous oxidized LDL or anything. They all relaxed just fine. So we again think that LOX1 is a critical component. So postpartum effects of excessive hypercholesterolemia pregnancy impaired the aorta for relaxation for later in life. And a schematic here is that we think that there's the LOX1, excessive oxidized LDL, results in that endothelial dysfunction. So just some perspectives of what I just presented is that this excessive hypercholesterolemia pregnancy contributes to both pregnancy complications, but could also lead to that later life cardiovascular disease. Complicated pregnancies, not just in preeclampsia. So there's a lot of women out there that may be at risk for cardiovascular disease at a very young age, like under premenopausal. We always think about postmenopausal women needing looked at for cardiovascular. I think pregnancy, any pregnancy complication can impact that. Assessing lipid profiles should be a standard of care. Again, I don't know what's done in Chile, but it's not done in Canada and most of the United States. And knowing who is at risk can offer an opportunity for cardiovascular screening and prevention, both while pregnant, but also later in life. And with that, I'd like to thank, of course, the lab that's there. The data that I presented was from Flora and Amanda and Tammy. And I just want to point out, Tammy in this picture, look at her with her Christmas hat on. So we miss Tammy in the lab. And thank you for your attention.
It's probably going to be a dumb question, but
No questions are dumb. Remember that, everyone.
have you thought about statins? Would they?
Yes, that's actually, so statins used to be completely contraindicated in pregnancy. They have now, that strong contraindication has been reduced relative to the guidelines, and I'm referring to American College of Obstetrics and Gynecology guidelines. What it is, it used to be that if women are on statins prior to them getting pregnant, prior to them getting pregnant and they get pregnant, they were taken off. It's like, okay, you're not going to have statins during pregnancy. Now people are allowing that. Would you want to start statins in pregnancy? Maybe not, because the cholesterol is so important for normal fetal development. And we don't even have a cutoff. So these cholesterol levels, when we have the epidemiology of human studies, is like 280 milligrams deciliter for cholesterol levels. But some women might go into the pregnancy a little bit elevated in cholesterol, and then the excess, so there's no cutoff right now to say, hey, this is a level that's really dangerous. So we need some more guidelines on the actual cholesterol levels that's there. But we're actually testing statins right now in the lab and finding that they're actually impairing that vessel function. You know how it relaxed and came back up? We only have an N of 2, but of those 2, if you're on the high cholesterol diet, the uterine arteries just don't relax at all. So it's like, I know, it's crazy. So I'd be very cautious of statins right now. I mean, again, we're using a rodent model, but that strong contraindication that has been relaxed, there's reasons for that. So we just don't want to just go off into everyone getting statins just because they have high cholesterol. Yeah. So that's a good question.
Uninformed. What about HDL?
Well, that's the problem with rodent models. You said HDL, right? Yeah, the rodent models have both elevated LDL and HDL and oxidized LDL. So the rodents aren't the best sometimes in studying this cholesterol phenotype. In humans, it's the ratio. So the LDL goes up, but the HDL doesn't go up as high. Yeah. Yeah.
Thank you. Yeah. I have a question about the response to methacholine in the uterine arteries.
Yep.
The discovery of the obligatory role of endothelium by Furgo-Sawowski was due to because some people was running those experiments and having a contractile response, and other people you have the same experiment having a relaxing response.
Yep.
To acetylcholine in the endothelium. Have you looked at this is also happening in the uterine artery? Because not all the arteries has the same response. Not all the arteries have muscarinic receptor in both endothelial and smooth muscle cells. So maybe there's any effect on those receptor by the diet?
Good question. So so acetylcholine or methacholine, which is an analog of it, can constrict smooth muscle but relax endothelial muscles, right? So we tested that, and there was no difference in the response to when you remove the endothelium. It wasn't a smooth muscle demise. The other thing that we did, again, was the, sodium nitroprusside relaxed just fine, and then we could reverse that. I guess the biggest indication is that we could reverse that phenotype in the presence of prostaglandin H1 synthase inhibitor. So there was an actual vasoactive compound being released. So I don't think it's a direct smooth muscle binding to it. That was my first reaction. It's like, oh, you've overwhelmed the endothelial response relaxation and it became a smooth muscle constriction. But we don't think that based on the pharmacological inhibition, and we did test removal of the endothelium.
And have you looked at some ion channels that also could be regulated by calcium releasing the endothelium and then having a lower response?
Yeah, no, we haven't. Yeah. no, there is much more that could be done in this field, which some are doing here. We'll see a poster later. Sophia, I see you.
Hi, Sandy. Good morning.
Good morning.
So I was just wondering whether this model of cholesterol supplementation during pregnancy is affecting the liver, and then the affection of the liver is going to release something, and then causing the phenotype rather than the I think that the question would be what happened with the liver, and also whether you haven't see any changes in the placenta. What would be the main target of that diet?
Good question. Yeah, the liver, you can see we have collected the liver, and you can see the liver cholesterol, and even the blood. You take the blood and it's all goopy. You can really tell that we've given these animals the high cholesterol diet. Whether or not the liver is actually releasing something to actually have an effect on the uterine arteries through LOX1, I guess it's possible, but we do have elevated oxidized LDL levels. So it is a model system, and we do need to keep that in mind. And then the placenta. Oh, we have some really cool data on the placenta. I was telling Gary that I'd have to pull it up because we looked at the ER stress pathway on that and the unfolded protein and gave some very interesting and differences between a male placenta and a female placenta. So I don't want to tell you the data without actually having the paper in front of me, so we can sit down and talk about. But yes, the placenta is changed. And we also have been looking at the cholesterol transport levels on that as well. But they actually go down. So we actually have been looking at the offspring, and there's some subtle phenotype on the offspring, but the placenta does a very good job of downregulating some of the cholesterol receptors and our transport and protecting the fetus. So it's amazing what the body does to protect the fetus, the placenta in that case, yeah.
Because I have the microphone, I can ask another question. So
Take that microphone away from him, guys.
Yeah. So I'm just wondering, what would be your bet regarding the supplementation with aspirin with the long-term consequences in the model? I know that you are doing right now, but do you think that changing during pregnancy, the system then gonna reduce the risk factor? Because that would be kind of exciting for the field.
I do. There's a few things here. We have, go back to your analogy, we have the chicken and the egg part of the story here. Yes, I think anything that you can do to reduce the severity of the vascular phenotype of that preeclamptic insult. So during pregnancy. So if aspirin actually reduces or delays the impact of the woman becoming preeclamptic, having that turbulent flow, to have that vascular resistance, will improve later life health because they wouldn't have gone through so much of an insult during the pregnancy itself. So I think that's part of it. But I guess the biggest thing is the screening. If it's 10 years out, maybe you should be thinking about looking at what are some of the cardiovascular risks you may have. Because right now, even as adults, it used to be every male over 55 got a low-dose aspirin. Now we've backed away from that, but if you're at risk, maybe you do need a low-dose aspirin. And maybe for women, they actually get put on that. And this is where the personalized medicine comes in. One day, hopefully we have algorithms where you plug in all these indices and then figure out which is the best treatment strategy or prevention strategy for both men and women, depending on their histories. Yeah.
Good morning.
Good morning.
Sandra. Nice the talk. I am thinking about I wonder if importance of the nitric oxide donors here in this, or how to involve it, the nitric oxide pathway.
Yeah, good question. Having nitric oxide donors, having pharmacological donation of nitric oxide. I see nitric oxide as, well, there's great papers out there, Dr. Jekyll and Mr. Hyde. Nitric oxide can be good and it can be bad, right? So, and I think under oxidative stress, which pregnancy as a state is an oxidative stress state, again, that cautiousness of understanding, and then also compartmentalizing. right? So inhaled nitric oxide to help your lungs is great because it goes straight there. But again, the nitric oxide donors getting to the right place at the right compartment is always a challenge as well.
Thank you very much.
Thank you.
Okay, so now we have next speaker and the last speaker. Is it not? Ah, yeah, it is. Yeah, so now we have next speaker and the last one. So now we have Dr. Gary Sick one time. So Gary Sick, él va a presentar ahora la última charla del simposio y nos presentará envejecimiento y control neuromotor del diafragma. So please, Dr. Gary Sick.
Buenos dias. That's it. That's it. So yesterday I talked about airway smooth muscle, and the smooth muscle is controlling the caliber of the airways. So it's increasing or decreasing resistance to airflow. Today I'm going to switch gears and talk about the major pump that drives the air into the lungs, the diaphragm muscle. So I'm basically a plumber, and it's very appropriate to talk about the diaphragm in the context of the heart. Actually, the two most active muscles in the body are the heart and the diaphragm. The diaphragm has a duty cycle, so the active period versus inactive period of greater than 70%. So it's actually more active than the heart. And another thing that's of considerable interest to me as I get older is the impact of aging. So this is a quote from Mark Twain that I think I presented here last year. Age is an issue of mind over matter. If you don't mind, it doesn't matter. I'm taking that to heart. There's a declining birth rate worldwide, but in the US and Canada, the birth rate is really plummeting, yet we're doing a lot to increase the life expectancy. So we're getting more and more people like me, old people, that are not being replaced by younger people. Now this is going to cause a considerable burden on the healthcare systems worldwide because there are chronic diseases associated with aging. So the financial burden will be huge in the future, yet the investment in aging research is not there. So I try to present this to my National Institutes of Health colleagues that we should have more aging research. I'll move over here. Thank you. Thank you. So the diaphragm muscle sits between the thoracic cavity, where the lungs are, and the abdominal cavity. So it acts as a bellows. So when it contracts, it pushes down, increasing abdominal pressure while decreasing intrathoracic pressure. That draws air into the lungs through the airways. That's called a transdiaphragmatic pressure, the difference, the pressure gradient between the abdomen and the thorax. Now, we asked very early on, well, how much pressure do you need to breathe? And we found that quiet breathing, eupnea, and all the way through to very forceful efforts, obstructive airways. So many of you in the audience probably have sleep apnea, obstructive sleep apnea, where your airways collapse and you try to struggle to inflate the lungs, but you can't, and you have to wake up to do it. And that recurs throughout the night. But even during these really strong efforts to try to inflate the lungs, you're not recruiting the entire diaphragm. So these are lower forces, lower transdiaphragmatic pressures, and only during airway clearance behaviors, voiding behaviors, straining behaviors, do you generate maximum pressure. Do you recruit the full diaphragm to generate those pressures? So think about it. When you cough or sneeze, you take a deep breath in and then cough. and you're building abdominal pressure by the contraction of the diaphragm. Well, I was going to mention to complicate things worse during aging, you have changes in lung compliance. So you have an emphysematous type of condition in the alveoli, which causes an increase in compliance or decrease in elastance. So expiratory airflow is normally passive, where you rely on the elastic properties of the lung and chest wall to push the air out. So as you get older, you lose that, and you end up retaining air in your lungs, and that also compromises the contractility of the diaphragm. Now, we model this in rats. I, too, don't like mice. And we use Fisher 344 rats. These are approved by the National Institutes of Aging as a model. And it's primarily because the male rats don't gain a lot of weight. In other studies, we use Sprague-Dawley rats. And these guys get really big, can exceed 1 kilogram when they get older. And they get mean. So we're using Fisher 344. So what we can do is put pressure transducers above the diaphragm and below the diaphragm and measure the transdiaphragmatic pressure. We can also look at the EMG signal, and we see a linear relationship between EMG amplitude, the RMS, the integrated EMG, and the pressure developed by the diaphragm. So we looked at the pressures. Whoops. Is there a pointer? Yeah. Oh, I see it. It changed. Anyway, we looked at the pressures developed by the diaphragm during different behaviors, so eupnea, hypoxia, hypercapnia. This is airway obstruction, and this is the maximum pressure that we could generate by bilateral phrenic stimulation. And what we found is that with aging, the stronger pressures, the higher pressures, were lost or reduced in older rats. So by older, we mean 24 months of age, and we determine that by the survival characteristics. So at 24 months, that's about a 50% survival in males. Females, it's a little higher survival, around 70% survival in females. Compared to 6 months, where there's 100% survival. Now, we also had data for 18 months, an intervening period. And I'm going to go back to 10 months based on what I learned while attending this symposium. So years ago, we were interested in the basic building blocks of diaphragm neuromotor control, and these are motor units. So a motor unit comprises a motor neuron and the group of muscle fibers it innervates. So these initial studies were done in cats, where we took the ventral root filaments from the cervical spinal cord. So the phrenic motor neurons are located in the C3 through 6 in the rat. We dissected single filaments or single axons, as much as we could, to isolate a single motor unit that was characterized by the force generated and the evoked EMG response. We then characterized what type of motor unit it was by its mechanical response. How fast was a twitch? How much force did it generate? And also by its fatigue characteristics. So we defined 3 different types of motor units: a slow twitch motor unit, a fast twitch motor unit, both of which were fatigue resistant, and a fast twitch fatigable motor unit that showed rapid fatigue when repetitively activated. We then used a technique of glycogen depletion. So we stimulated these things a lot and depleted the glycogen stores in the muscle fibers. Then we could identify the fibers belonging to a single motor unit, and we determined the fiber type within each of the motor units. So slow twitch motor units have a type 1 fiber, or a slow fiber. Fatigue resistant have a 2-way fiber type, and fast fatigue will have a 2x2B fiber type. We characterized the mechanical properties of these motor units, and we made an assumption that for something like breathing with a duty cycle of 70%, we would want to recruit only fatigue-resistant motor units. So that's an assumption. If you recruited highly fatiguable motor units, it would be of no value because you would fatigue the muscle. So knowing the composition of the motor units in terms of fiber type, looking at the fiber type distribution in the muscle, making certain assumptions about recruitment, we came up with a model for motor unit recruitment during different motor behaviors. And what we found was that the breathing efforts of the diaphragm could be accomplished by the recruitment of only fatigue-resistant motor units, which made sense to us. As you increase the efforts, possibly during airway obstruction, you start to recruit some of the more fatigable fast-twitch motor units. And certainly during coughing, sneezing, voiding behaviors, you recruit these highly fatigable fast-twitch motor units, as well as the fatigue-resistant motor units. Now, the recruitment of motor units depends on the size of the motor neuron, based on intrinsic electrophysiological properties. So the input resistance is different between motor neurons based on size. So you recruit small motor neurons first, large motor neurons last. We could determine the size of the motor units indirectly by looking at the size of the axons by measuring axonal conduction velocity. Smaller axons have slower axonal conduction velocity compared to larger axons. By knowing that, we could look at the recruitment of motor units based on axonal conduction velocity and found that smaller motor neurons with slower axonal conduction velocities were recruited first during efforts, again consistent with our model of motor unit recruitment. Now, what scares me to death is that I'm losing motor neurons as I get older. And the motor neurons that I'm losing are larger motor neurons. Now, this is consistent with what has been found in ALS, for example, where you have motor neuron loss. It's motor neuron disease, and there's motor neuron loss, and the motor neurons that are lost are larger motor neurons. So aging is a slow form of ALS. Well, we proposed that in the past. We can do that by retrograde labeling the motor neuron pool with cholera-toxin B, which binds to gangliosides at the presynaptic terminal, gets taken up, and then transported back to the motor neurons. And we can then image these labeled motor neurons using high-resolution confocal microscopy, go through the entire pool, count the number of motor neurons, and that's how we came up with this. Both the number and the size distribution. This is somal surface area. At the same time, we can look at the presynaptic terminals in relationship to the postsynaptic elements, the neuromuscular junction. And what we found is compared to 6 months, where we see both in type 1 and 2A and the 2X2B fibers, where there's good overlap between pre- and postsynaptic elements, that in older rats, there's withdrawal of the presynaptic terminals at the neuromuscular junction. So this presents a chicken and egg question for us. Which is it that comes first? Is it the retraction of the presynaptic terminals that causes the problems? Or is it a die forward where the motor neurons die? And what we're seeing is the loss of innervation. And we just don't know right now. But there is denervation of these muscle fibers. So we asked, is it the denervation that's causing the changes in the contractility of the diaphragm? And this is complete denervation of the diaphragm. So we cut the phrenic nerves. We wait 2 weeks, dissect out single fibers, put the single fibers between a force transducer and a servomotor, measure the mechanical properties of each of the single muscle fibers, and then look at type 1, 2A, 2X2B as a reflection of what would be happening with motor units. And this is maximum specific force per cross-sectional area. There's a decrease in each fiber type, but a much greater decrease in type 2X2B fibers after denervation, only 2 weeks after denervation. When we looked at the cross-sectional area fibers, actually there's slight hypertrophy of type 1 and 2A fibers, but a marked atrophy of the 2X2B fibers. So this defines sarcopenia in other muscles. You get a muscle wasting, shown here, and a decrease in specific force, which is, again, a characteristic of sarcopenia. So we concluded from this that the diaphragm is susceptible to sarcopenia, and that may be explaining some of the changes in mechanical properties that we observed. Now, more recently, a graduate student in my lab, Genesis Hernandez, has been looking at this again, but further looking at the mechanical properties. So again, we found that there's an atrophy of 2X2B fibers and a decrease in force, specific force of the diaphragm. But here, this is the force-velocity relationships of the diaphragm. So you can see the reduction in maximum specific force here, but at each load, there was a slowing of the velocity of shortening. Now, the product of force and velocity is power. So the power output of the diaphragm in older rats is reduced compared to younger rats. Now, this has implications on the energetics of the muscle, because there's a direct relationship between power and ATP consumption. So to summarize this part, the diaphragm is vulnerable to sarcopenia. It has an impact, but primarily on these higher force behaviors of the diaphragm. So my mother unfortunately passed away, but she almost lived to 100, just short of 100, and she complained about her ability to cough, to clear her airways. Apparently that's a hallmark of older people, that they have difficulty clearing their airways, they get mucus, and they complain about that. In fact, they're more vulnerable to airway infections and pneumonias. So what we think is going on is they can't clear their airways because they're losing fast-twitch motor units by a sarcopenic effect. This has an impact on their ability to generate higher forces and cough and sneeze. But their breathing is perfectly intact, their ability to breathe, which is a good thing. So we asked the question, what could be causing the loss of these larger phrenic motor neurons? We want to come up with some therapeutic target that we can address and try to prevent the loss of these larger motor neurons. It could have implications in treating ALS in the future as well. So we and a lot of other people are interested in brain-derived neurotrophic factor, which binds to its high-affinity TrkB receptor, the full-length TrkB receptor. When it's activated, it activates a protein kinase. The receptor itself is a protein kinase, but it has downstream signaling effects, and I'm going to show you those as well. One of those is CREB, and the phosphorylation of CREB at the serine 133 site. CREB is a transcription factor. I showed it yesterday in relationship to airway smooth muscle. So it also exists in phrenic motor neurons. So we hypothesized that a reduction in this BDNF TrkB signaling and its impact on CREB phosphorylation could be important because it would diminish mitochondrial biogenesis and lead to a dysfunction of mitochondria. Now, to study this, we generated a rat model. Unfortunately, it had to be on Sprague-Dawley background. We worked with Charles Rivers, and this is an engineered rat. And what we do is a point mutation, a substitution of phenylalanine to alanine in the TrkB full-length kinase domain. And what this does is it renders it vulnerable to a kinase inhibitor called 1-MPP1. So if we give 1-MPP1 in the drinking water, it very rapidly inhibits the kinase domain of the TrkB receptor. We can remove the 1-MPP1 from the water and it reverses. So this is not a deletion type of study, but a chemogenetic model. And by doing this, we can inhibit the TrkB kinase for periods of time. So what I'm going to show you is our study is looking at 14 days of inhibition of the kinase, TrkB kinase receptor. So this is the impact of BDNF on Krebs phosphorylation. And when we gave the 1-MPP1, we saw a reduction in phosphorylation of Krebs. Now, Krebs acts with another protein called activating transcription factor 1, ATF1, and they're co-transcription regulators. So that's why you see both Krebs phosphorylation and ATF1 phosphorylation. And you can see here a pretty dramatic inhibition, particularly of the ATF1. We first looked at the impact. Again, remember that there's retraction of the presynaptic terminal that would make the neuromuscular junction susceptible to transmission failure. And we do that, we developed this technique years and years ago where we stimulate the nerve repetitively, measure the force response, that's shown here. So this is fatigue of the muscle. Every 15 seconds, we would stimulate the muscle directly, and this is muscle force. If there's good fidelity in the transmission, then the two are closer to each other. So at 24 months, there was less decline with nerve stimulation. That means neuromuscular transmission failure is occurring. So here, I hope you can see, it's not very good. Control are shown here. This is the decrease or the extent of neuromuscular transmission failure with repetitive activation across a 2-minute period. If we gave BDNF in the solution, we saw that there's an improvement of neuromuscular transmission. When we gave 1-MPP1, a dramatic reduction in neuromuscular transmission. This is in younger animals. In older animals, there was no difference. So the BDNF is not facilitating neuromuscular transmission, and 1-MPP1 is not impairing neuromuscular transmission. We then looked at the effect of 2 weeks of inhibition of the TrkB full-length kinase activity on the number of motor neurons. So again, trying to mimic what could be occurring in older animals, but on a much shorter time scale. And what we found was just after 2 weeks, there was a 20% reduction in the number of phrenic motor neurons. And these were primarily larger motor neurons that were lost. This is the distribution of motor neuron size. Here we looked at the BDNF TrkB-induced Krebs phosphorylation and whether or not the Krebs here targets the PGC1 alpha. I showed this yesterday for airway smooth muscle. And each tissue and strain of rat, et cetera, has to be tested independently. And we used a chip. We identified the promoter regions that could be responding, and then we looked at the chip assay and the impact of BDNF, which produces Krebs phosphorylation, on the binding of Krebs to that promoter region. We then looked using immunohistochemistry. These are preliminary results that this is PGC1 alpha. PGC1 alpha should be localized to the nucleus. It was with immunohistochemistry. And it looked to be a higher level of immunoactivity in the nucleus of smaller motor neurons compared to larger motor neurons. So this is work still in progress. It's very laborious work, but we'll get it done. When we looked at PGC1 alpha compared to controls, if we stimulate with BDNF, this is mRNA and protein, In both cases, there's an increase. So BDNF does trigger Krebs phosphorylation, which downstream increases PGC1 alpha expression. And then downstream of that is mitochondrial transcription factor, TFAM, which is also elevated. This is important because TFAM is involved in mitochondrial DNA replication. So this summarizes all the effects and then looking what happens with 1-MPP1. So this is the CHIP assay. So BDNF increases binding, but when we give 1-MPP1, it's still increased, but it's to a much lesser extent. When we looked at PGC1 alpha and TFAM expression, again, 1-MPP1 reduces the effect of BDNF treatment in every case. So we are inhibiting the TrkB kinase, and we think this signaling pathway is activated by the TrkB full-length receptor, the kinase domain of that receptor. So why are only large motor neurons susceptible? What we think is going on is that the smaller motor neurons are very, very active, and there are other signaling pathways and activity-dependent pathways, most likely signaling through a MAP kinase pathway that target Krebs phosphorylation. That's why the smaller motor neurons would have a higher level of PGC1 alpha expression, possibly. We think that larger motor neurons are totally dependent. They're very infrequently active, so they don't have much activity-dependent production. But the BDNF TrkB full-length signaling pathway is a way to keep them alive, to keep mitochondrial function viable. So both would target the same pathway, PGC1 alpha, that would then go downstream for mitochondrial biogenesis and replacement of mitochondria as they're being damaged. So mitochondrial homeostasis is a very complex thing, so I've only focused on mitochondrial biogenesis. We also see changes in the fragmentation of mitochondria. As I get older, my mitochondria, particularly in larger motor neurons, are becoming more fragmented. That's probably a reflection of mitochondrial damage and production of reactive oxygen species that cause that damage. So we think that this pathway is a reflection of damage. You have to basically squeeze off the damaged regions of mitochondria to have them replaced. That's quality control of the mitochondria. And that leads to mitophagy, again, recruitment of PINK1 that I talked about yesterday, activation of the PARK and the E3 ligase. These are all good things for mitochondrial quality control. But if they become imbalanced, that becomes a bad thing. So we think that with aging, there's an imbalance between mitochondrial biogenesis and mitophagy, that mitophagy pathway still exists, but mitochondrial biogenesis is reduced. And because of that imbalance, the quality control of mitochondria is affected, diminished. And so large motor neurons become susceptible to this. Now, this occurs with aging, but we think it also occurs with ALS. And we currently have a rat model for ALS as well. And it could be possibly in other neurodegenerative conditions like Alzheimer's disease and Parkinson's, where mitochondria have been implicated in the past. So again, I showed you this yesterday. Matt Fogarty is somewhere in here. Matt is from Australia. He came and has been a driving force for this research over the past, as well as a number of other people within the lab. All right, thank you very much.
¿Alguna pregunta para el doctor Garisi? Les tengo que informar que vamos a tener que abandonar rápido esta sala porque hay otra actividad que se va a desarrollar en esta, de manera que vamos a tener que abandonar el lugar pronto. Y lo otro es que está garuando y por lo tanto tenemos que cambiar el lugar de los pozos, pero en el edificio del frente. ¿Alguna pregunta entonces para el doctor? Ahí sí.
I have two questions. One is maybe very silly. I mean, is there any measurement about the effects of laughing and
Of what?
of laughs?
Laughing. Oh.
Laughing.
Well, the diaphragm's involved in all sorts of behaviors.
Yeah.
So laughing would be one, but swallowing. So as you get older, you have dysphagia, you have problems swallowing, all sorts of things. Generation of intrathoracic pressure is important for getting the bolus of food down into your stomach. When you have a dysfunction, you know it. I don't know if anybody here has had problems with swallowing, where you get food stuck and you can't clear it, and you struggle. So I often work with head, neck, and physicians that are primarily focused on that aspect.
And the second is very general, because hand grip force, for instance, is used as a predictor of healthy aging.
Hand grip force?
Hand grip, yeah, hand grip.
Yeah, that's
force.
ridiculous.
Yeah. Yeah. And
Sorry,
yeah,
I
yeah.
shouldn't say that.
Yeah, and I was thinking it's more maybe use the diaphragm, activity as a predictor to.
Yeah. So I had a clinical trial with colleagues that I convinced in cancer patients. So cancer patients that were malnourished and lower body weight because of that were much more vulnerable to mortality, and they died earlier. And so we were looking at using a sniff test. So one way that you can measure the maximum force of the diaphragm is do a sniff and measure the pressure changes basically in the airway. So we did that, and we were interested in the impact of vitamin D, the bioactive form of vitamin D. And we were replacing the 125-dihydroxy vitamin D in these patients. I don't know the outcome yet because it's been blinded, but it continues, so it must be some outcome.
Really nice work. Just curious about the last statement you said, that you have a rat model of ALS. Mm-hmm. Is that rat model made by manipulating some of the pathways you've identified, or how?
No. This is available through Jackson Lab.
But what did they do to make it an ALS rat? Just curiously. And then how did that interface with your...
Most of the models are affecting, this is a superoxide dismutase model.
Oh, okay.
SOD model. But most of the models impact mitochondrial function in some way, either by changing the scavenging of reactive oxygen species or mutations. I can't remember exactly the protein that's been mutated, but also in the mitochondrial ROS scavenging pathways.
Okay, thanks.
Yeah.
Okay, thanks very much.
All right, thank you.
Entonces ahora nos desplazamos hacia el edificio R3.